Hi, this is Tyler Kirk. Thank you for watching this video about an intumescent cataract. Uh, this cataract has been formed due to blunt trauma to this young patient's eye. Patient is completely blind from this cataract with only hand motion vision. Staining the anterior lens capsule with trypan blue capsular dye as there is a total absence of a red reflex. Now, dispersive viscoelastic is being placed into the anterior chamber, and the most dangerous part of the cataract surgery in these patients is that this lens is swollen, and there's liquefied cortex, and there's a need to decompress the liquid cortex in order to safely perform a continuous curvilinear capsulorhexis. So I placed a 30 gauge needle into the eye and removed liquefied cortex to decompress the situation, then going about making my normal capsulorhexis. And I like to make a somewhat large capsulorhexis in these cases to give me free working room with these lenses. But initially need to be very careful because that capsule can run around and create a very different surgery if the capsule runs out and creates a posterior tear, which would then introduce vitreous into the surgery. And so we avoided that and have a successful capsulorhexis there. Now, uh, freeing up any liquefied cortex from behind and getting the nucleus to be able to freely be mobile. And that is happening there. As you can see, a lot of the cortex egressing out of the main incision. Now, phaco emulsification to remove the nucleus of the lens. I'm sculpting the lens into uh, uh, half, and then we'll break that and take the lens into quadrants and then remove those. These types of lenses that are completely opaque like this can be from multiple causes: diabetes, long-term steroid use, prior surgery, and radiation exposure or exposure to extensive infrared light can cause these types of cataracts. The most dangerous are the ones from prior blunt force trauma or patients who've had complicated prior surgeries. The risk for zonular loss, and the zonules are what hold a lens centered in position, and if those are lost, then the stability of the structure in which you're removing the lens is lost, and it makes it quite difficult to safely remove the lens. In this case, while I was removing the nucleus, I could tell that there was excessive movement of the whole capsular bag complex, so clearly there had been some loss of some of the zonules. And so while I was able to safely remove the nucleus and get the cataract out without issue, and there was no vitreous that presented around that area of loss of zonules, I did want to make sure that we provided the patient with some additional support for the long term. So here the nucleus has been removed, and now you can see that there's a nice red reflex. This is an utterly life-changing procedure for patients. It's just such a gratifying experience to be able to provide this to a patient because it just allows them to go from being blind to being able to be functional and see again, and it's just the most dramatic of experiences for both the doctor and patient. Here, cleaning away any residual cortex that's along the uh, capsule. Cohesive viscoelastic to fill the capsular bag. Intraocular lens implant is being introduced now, and it's now unfolding into position into the capsular bag. Now that is a capsular tension ring, and so I'm loading it into our delivery device, and then we'll go in through the main 2.4 millimeter incision and place that into the capsular bag, and that device is going to tent out the capsular bag, allowing the intact zonular fibers to provide additional support to the other areas by uh, bringing tension within the bag complex, and so the lens will remain steady and in centered position and leave the patient with less likelihood for issues in the long term, as late decentration is a risk in anybody with zonular compromise. Removing the viscoelastic, inserting moxifloxacin, hydrating the wound, and this patient did fabulous. Thank you for watching.